Models work group agenda. So it's back to school time to begin working on an agenda for the year. Let's go around and introduce everybody at the table as well as anybody who might be on the phone. I'm Donna Kinzer with HSCRC.
Shula Gerovich, HSCRC.
David Romans, HSCRC.
Stu Gutterman, Academy Health.
Bob Murray, representing Pier.
John Hamper, Care First.
Cynthia Swag, United Healthcare.
Hank Franey, University of Maryland Medical System.
Ian Meck, University of Maryland School of Nursing.
David Johnson, Simpson Consulting.
Mike Robbins with Maryland Hospital Association. Vinny DeMarco, Maryland Citizens Health Initiative.
Kristen Polio, Adventist Healthcare.
Steve Kravitz, Johns Hopkins Medicine.
Shannon Mcmahon, I'm the Deputy Secretary for Healthcare Financing at DHMH.
Raymond Gray, Trivergent Health, 3 hospitals in Western Maryland.
Mike Curran, MedStar Health.
Barbara Bricado, Bricado & Associates.
Andy Udoms, Head Office, Head Services Cost Review Commission.
Jerry Smith, HSCRC.
And on the phone, so they're not able to speak either right this minute. Okay, well, when we're there, we can come back and find out who's on the phone, and we'll get back to that then. We have 4 agenda items for today. The first is discussing a review and discussion of the Health Job Opportunity Program. The second, a market shift update. The third, to discuss the performance work group work plan. And then finally to begin discussing the approach to analyzing efficiency. So the first agenda, so I'll move back to the first agenda item, which is to discuss the Health Job Opportunity Program proposal, and we're at the last commission meeting. Several hospitals brought forward a proposal to create community-based jobs, to create employment opportunities in economically challenged areas. And I know we sent out the proposal that was presented to the commission, as well as the PowerPoint that accompanied that proposal. And I just want to make sure that that folks around the table has everybody had a chance to review those documents if you weren't at the commission meeting. So I just want to everybody had a chance to review those documents so that we're not having to go back through an overview or a detailing of the proposal again. Everybody had a chance to review those documents. So I guess what we had is a series of questions that we sent out, and we can try to take them in order, or we may end up winding around a little bit in the questions, because some of them may be things that we want to come back to after we think about some of the other questions. But so we sent out the proposed list, and I know that you all should have a copy of that in front of you. I guess, you know, maybe rather than going through one question at a time, I might like to really open it up more generally to ask folks to comment on their thoughts in general, and then we can go specifically question by question if that's a good way. But let's start out with a more general opportunity to comment as opposed to a structured one. Is there anyone who wants to go first? Bob.
Yes, thanks, Donna. Well, let me preface my comments by just saying that obviously this proposal is geared toward trying to do the right thing by helping disadvantaged communities within Baltimore. So that's clearly the motivation, and I think the hospitals should be commended for that, obviously. Now, having said that, I think they're in looking at this proposal in a fair amount of detail and thinking about it for the last several weeks. There are a number of pretty significant issues and weaknesses that leap out. One is just the potential precedent that it sets, whether it's a potential slippery slope for funding things that are not necessarily very effective in the context of the current waiver or phase 2. There are also issues about the legality of the funding, whether the HSCRC as a public utility really has the authority to fund positions that are not hospital positions. Generally, public utilities do not have the authority to fund, to assess taxes on the regulated rates that they establish for things that are not related to the costs of the entities that they regulate. So I think there's a concern and a consideration there. If these jobs are hospital jobs, entry level, such as janitorial, dietary types of staff, then there's a question as to whether those positions are redundant. And if, particularly in the context of the demonstration, funding redundant positions and adding to an industry that already arguably is too large, whether that's consistent with the purpose and the objectives of the demonstration, which is to contract that industry because of the inefficiency and the waste that we all acknowledge exists in healthcare. I think the other key areas of concern are the lack of specificity and detail in the proposal itself. While, again, well-intended, unfortunately, there is, one could say that the proposal is sketchy at best in terms of the detail that's provided. And unfortunately, it's been sort of dumped in the lap of the HSCRC to work out the details and work out whatever reporting is required, right at a time when we're getting close to having to provide a plan to the CMMI with regard to phase 2. And so it redirects resources both for staff and also for work groups like this that should be focused on phase 2. I think there are also issues about the funding that should be addressed. To do a specific assessment for something that is questionable in terms of its legality for the HSCRC is of concern. However, the hospitals have been given significant discretionary funds, and that's sort of a quid pro quo with the Commission. Oftentimes, the hospitals are given funding and amounts in their budget, and then they are able to exercise flexibility in terms of what they want to spend their money on. And in this case, there's both the substantial infrastructure that's been built into rates as well as the transformation grants that would be applied for by hospitals. And it seems to me that this type of activity will lend itself more to being funded out of the infrastructure monies that have been provided. I would also note that profitability in the industry has improved significantly over the last 3 years, and I don't think that's a bad thing. I think that's a good thing. That was part of the intent of the program. Early on, we talked about global budgets as being an opportunity to reduce waste in the system, and by reducing waste, that's a form of financial sustainability, and that's indeed, it appears, is what has happened 13, and 14, and 15. And profits have increased considerably, so that's another source of funding. And lastly, I would argue that this activity is consistent with hospitals' community's mission and their requirement under, due to the advantages that they have with tax exemptions to fund activities that benefit the community. And with fairly sizable drops in charity care in recent years, it seems like this is a natural activity they could devote their resources to and backfill and at the same time provide, fulfill their community benefit obligation. So let me stop there, and I'd be happy to take questions or comments, or if you want to go around the room, that's fine. Thank you.
Next commenter, Ann.
Yeah, I'm speaking from the perspective of nursing, and if the purpose is to try to create jobs in inner city Baltimore and severe poverty levels, I think that this would be a good mandate, because certainly hospitals have been the employer of people from all income strata, especially the inner city hospitals. And nursing itself, for example, has been a career pathway for many people from high school education all the way up to doctoral preparation. That said, I'm also concerned about how this would work from the standpoint of who's going to watch the community health workers, what scope of practice they're going to have, who's going to supervise them. I know the Maryland Board of Nursing has been very concerned with the idea of community health worker providing some kind of health education or health counseling under whoever supervision, and how that would be effectively carried out, so that a patient out in the community might think that they are getting solid advice from somebody with health education when in fact they may not have that. Community health workers have worked well in third world countries in Africa. I'm not sure that that model is translatable here to the United States. So from the standpoint of an employment model, this may seem like a good idea, but from the standpoint of sound patient care and patient safety, I'm not sure it is.
And there are other jobs that are outlined in there. It's not just community health worker. There's other jobs that are included in there. Yes, sir.
Sorry, you can't see my name, but Steve Kravitz, representing Johns Hopkins. I appreciate the comments from Mr. Murray, in particular detailing some of the concerns, and then from Ann about the concerns about implementing. I think that these are extraordinary times, that we have a responsibility, a social responsibility to the public trust, and a modest, considering the magnitude of the dollars, investment back in the community, spread across all of the stakeholders, seems absolutely appropriate. I think to address the specific concern about the legality, it's our position that the HSCRC does have broad scope and authority to address population needs, and indeed, over the coming years, the entire waiver program is going to be built upon, a global cost, which largely is going to be shifting more and more emphasis into working in the community. So we do believe that the proposal itself is well within the scope of the HSCRC, and to address the issues about where the funding should come from. The hospitals in particular have been using the funds appropriately, as has been outlined by the Commission with regards to rate regulation, but this is extraordinary. This is 1,000 positions, 1,000 jobs, new to the community, and the funding for those would be appropriately outside of the scope of the original waiver. In addition to that, there's still a significant amount of in-kind support that the hospitals and systems would need to invest in the training. I think to address, the concerns about whether the hospitals are funding their share, there's certainly a tremendous opportunity to do that. So I think, given the magnitude of the situation that we're in here in Baltimore City and the state of Maryland, to do the right thing, and the scope of the authority, the Health Service Cost Review Commission, to take this on, we feel pretty strongly that it's in the scope and it's the right thing to do. I think the key to success is to create an oversight committee, as has been done before with regard to nursing. And that oversight committee can answer a lot of the details that do need to be fleshed out. And certainly folks from Hopkins, and I would imagine some of the other systems represented here, would be willing to invest their human capital in helping to drive that forward as well. So we do appreciate the opportunity to present this proposal to the Commission.
Any?
Thank you very much. I was here when Ron Peterson presented this proposal to the Commission, and I can tell you, as somebody deeply committed to Baltimore City and the state of Maryland, our organization, Healthcare for All Citizens Health Initiative, think this is a great concept to have this BHSCOC look at and figure out how to do this. If we could do it, it would be great. We are very pleased that Johns Hopkins reached out to us, as well as 1199 SEIU, Care First, and other stakeholders to try to work out the details. And I know, as Bob raised, there are questions that have to be addressed. I'm hopeful that can be done. We hope that something like this can be done, but we understand that it has to be done properly, and this is something new, and we hope that all the stakeholders will continue to be listened to make this something that we can all be on board with.
Ray?
So there are a lot of poor people in Maryland, and they don't all live in Baltimore City. I think Somerset and Allegheny counties are the two poorest counties in the state, for example. And there's been a tremendous loss of jobs in the rural areas in Western Maryland and in Southern Maryland and the Eastern Shore. And there has been attempts in the past to create jobs programs in Allegheny County. There was one that was done with DSS in the county, and it failed. If there's a new approach that could make it succeed, we're for that. I don't think the focus should just be Baltimore City here. I think it should be the state of Maryland. And I believe in talking with Mike Robbins, MHA is prepared to, or has put forth a proposal that has to do with, poor, the measure of poor or poverty or job loss in any region of the state. I think that should be considered if this is going to go forward. I think also that all of us face a wealth of challenge today in terms of the workforce. Level of education, diversity. I know there are diversity programs at Frederick to reach out for the diversified community. There's a diversity or a Bridges program in Frederick. I misspoke. And there's a Bridges program in Allegheny County to try to create jobs. And perhaps all of those programs could join together in this endeavor, but I would not support a program that was focused on just Central Maryland. It ought to be statewide. I did a little Google search when I saw this on Friday, and as you do all things today, you look up Google, and I looked up jobs program. It took me right to the Department of Labor, and they have a number of programs there that are available for us to consider. Thank you.
I'm just going to try to clarify. We don't have any specific proposals. I think what I clarified before the meeting is that as this program was presented, and I think it's clearly stated in your materials, this program was not designed just for Baltimore City. As outlined in this program, it's any zip codes throughout the state that have high unemployment or high levels of poverty. The standards that were used or recommended here were unemployment of at least 10% and a poverty or a poverty level of over 20%. And we have zip codes throughout the state, Western Maryland, Southern Maryland, Eastern Shore, that would be eligible. So I think this program was always designed that way, although the effort was certainly led by the hospitals in Baltimore City. The other thing that I will comment on, I just don't know if we have the data, is that when we presented this to the commission, Commissioner Loftus raised the question about looking at things at a sub-zip code level, because you may have some zip codes throughout the state where there's less than 10% unemployment, but within a substantial share or sub-zip codes of those overall zip code areas, there might be greater than 10% unemployment. I don't know if we have that data. That is certainly something that we can look at to respond to Dr. Loftus's question that she raised at the commission meeting. But I want to make sure that it's clear this program has always been designed to be a statewide program.
So as stated, then it's a statewide jobs proposal program to create jobs in areas where there's employment problems in the state. So that's how the, unemployment and poverty, and that's how it's being framed as such, so as you stated. I just want to give other folks a chance to say something before we're back to you, Bob. So other folks, Shannon.
Hi, everybody. I'm Shannon Mcmahon. I'm the State Medicaid Director. I'm glad to be here today for my colleague Tricia Roddy. First, I think Bob and others have done a great job of articulating some of the concerns from the payer's perspective. I first need to say that I work for the governor, so jobs are #1 for the governor. But I do want to say that I think I agree wholeheartedly with what Bob said about there already being a mechanism. And as one of the payers who'd be responsible for paying about 20% of this cost, I think it's important for us to express concerns about accountability and what exactly would the accountability back to Medicaid look like here. I don't think we agree. We actually shared a letter with the commission that this would actually lower Medicaid roles. We actually think it might increase Medicaid roles depending upon the types of jobs that are created here. I also want to say that we have a role in this to play too. The state and the Department of Health and Mental Hygiene just reopened our hiring freeze. So the opportunity to get jobs with the state, particularly in Baltimore City with CHMH, is wide open again. And actually just on Friday, I released an additional $1.85 million to the local health departments to do hand-in-glove, on-the-ground work, helping people get through the Medicaid redetermination process, which I know is a huge issue for all the payers as well as the provider community. So I want to say that we very much have a role to play in this, but definitely agree that there's a mechanism there through the infrastructure monies, both this year and in the future years. And want to just underscore that we definitely feel like we have a place at the table on this, both from a payer perspective, but then also as the role of an employer. So want to just share those concerns both on behalf of the Medicaid program as well as on behalf of Secretary Mitchell at DHMH.
Don? Just, I'd like to reiterate some of the steps or the points that Care First has made, and United Healthcare is an MCO in the state, so we wanted to take a look at how does this affect Medicaid, the Medicaid population as well. The types of jobs that are listed in the proposal, there's not a whole lot of detail, but we were concerned, as Ann was, for those folks out in the community, would they be seen as healthcare professionals? So that was one of our concerns. We believe the infrastructure dollars are there, as Care First does, but we'd like to see more details on the program. When does it stop? When do we think we're successful? Is it going to be really statewide, or will it be directed to the urban areas? So those are United comments so far.
Barbara? Oh, excuse me. Barbara Brocato, and I guess I'm here mostly on behalf of the physicians. I represent a number of physician specialties, both professional societies and contract groups that contract with hospitals throughout the state. And here's my gut is that this just feels too early. We're in the initial stages of stage 1 with our global payments just on the hospital side. We don't have a sense of the outcome data there. We're, very on in trying to figure that out just on the hospital side. We're looking at brand new delivery models, different relationships, community clinics, physician to physician, physician to hospital, nursing home hospitals. I just feel like that there is the growing need, and we're all dedicated to, better access and better outcomes and more efficiency, but that questions that have been raised around this table are fundamental questions, and we haven't even got it figured out in terms of enough data on the hospital to know what these initial stages have meant. I know the physicians that I work are seeing different patient flow on an outpatient basis than they were before the new waiver. So I really feel like this is a great concept, but it's a little early. And I go back to what was stated earlier. I think also, are there other payment sources that could be identified for a program like this? So, thank you.
Any other general comments?
Don?
Mike?
Just the drive behind this was the desire to do something around, obviously, an acute situation that was occurring in Baltimore at the time, and it was driven by the need for someone or some people to step up and take action that would help a community that's in need of help. I think it's developed into a more comprehensive program appropriately dealing with other parts of the state that have challenging issues. I actually appreciate all the questions, and I think there's a lot of legitimate questions as it relates to how do you control it and what's a true cost and what individuals should be doing. But I just don't want us to forget where it came from. And we looked at it as people do need to step up and make a difference. It is a part of our community mission, and as appropriately pointed out by Steve, there's a lot of indirect costs that will go into this that won't be covered by this program, but it was an attempt by the hospitals to step up and do the right thing. I do appreciate all the questions that are being there, but we felt that there was a need to do something special in this unique set of circumstances, and that's why we're doing it. And again, whether we can work out all the details and whether it comes through, we'll see, but it felt like a time of action. And we jumped in with the other folks to say maybe it is time to do something. And I appreciate all the efforts of the state, and those will have to chip in to make it happen. But that was really the driver behind this. And I don't think it should get lost in all the legitimate questions related to how do we control it appropriately.
And I think you make an extremely important point. This is first and foremost a job creation program. To create jobs to do what remains to be seen, but it is a job creation program. My question would be, is this the best vehicle to do it through the hospitals, or would the state be better stepping up to the plate and funding state and local health departments more to create where the places where these community health workers or other people should sit to be able to keep people healthy? That's the traditional role of a health department out in the community, so that these people may never even come in contact with the hospital, the patients. So the question is that if this is just a job creation program, placing it in the HSCRC's purview with extra funding may not be the most appropriate place to do it. Certainly unless we know exactly what the jobs are supposed to do and how that's supposed to further the mission of HSCRC, which is containing hospital costs and keeping hospital costs on a lid. So my question would be is that this is not necessarily the best place or best vehicle to fund something like this through extra revenue. If the hospitals wanted to do this type of mission with the existing funds that are already allocated, that may be the best place to do it. Certainly hospitals have had workers that have helped patients sign up for health insurance for decades because it's in their interest to do that. So allocating extra money to do that may not be appropriate. Putting money out into the community just to have people employed without a clear idea of what they're going to do, how they're going to be accountable, is probably ill-advised at this point. And there may be other options, as I say, looking at state and local health department funding that would be much more appropriate to do that kind of a mission.
David?
I'm struggling with the balance. So here we are on one side of the equation trying to be lean, efficient organizations, and then on the other side of the equation we're talking about creating jobs. And maybe the money needs to go into education or into training as opposed to creating jobs just for the sake of creating jobs. Because I don't know how I tell one segment of my employees we need to be lean and efficient, but we're going to create jobs just to create jobs. It's a great cause, and I agree with it, but I'm struggling with how to get that balance with my organization.
David Johnson, I just want to say on behalf of the employer community that's also funding a large portion of the hospital bills, I also wonder about, is this the most efficient means for employing these folks? do we know it's really more efficient to have it run through the hospitals or run through the health department? And to what extent could it make more sense to have these folks employed by Department of Health and Mental Hygiene? That, to me, that's a big question. And is the business case really convincing that this will, in fact, if it's held on the hospital side, will it both improve care and reduce the overall cost? I think if the business case truly is there, that it will reduce cost and improve care, and it's more efficient to be done through the hospitals versus DHMH, then I think the business community, the employers, could support it, but only if the business case is there that it will, strong evidence that it will reduce cost and improve care, and that it's more efficient to have it run through the hospitals than through DHMH. Could I add, just want to respond to a couple of the comments that were made. First, I think the way this program has been proposed, there is clearly an intent to look at the outcomes of this program. And the intent is, if there's not a demonstrated return from those funds being invested, then you pull those monies back out of the rates that are being proposed to be funded here. That's very similar to what we've done, for example, with the Nurse Support 2 program, where we've put money in rates for hiring and training of nurses. There is an annual reporting to the Commission as they consider the continuing funding of that program, where they look at nurses trained, nurses hired, and other metrics to support the continuation of that program in rates. So I think very much like that nurse support program, the intent here is to do the same kind of evaluation on an ongoing basis. And if there's no demonstrated return or outcomes of benefit to the community, then that money clearly would have to come back out of rates. It's also one where you need to be able to demonstrate that the folks you're employing remain employed, so that if you hire people with these funds and then a year later those folks are no longer employed, again, there would be no reason to continue that funding. I think that was all the intent of what's behind this program. In terms of whether this is the best way to create jobs or expecting the government to step forward, whether through enhancements to state and local health department funding to support this kind of effort, all I would suggest in response to that is we have nearly $700 million in our rate structure supporting a whole range of functions that one could argue are more appropriately the role of state and local government. And yet we've used the rate-setting system, whether it's assessments to expand the coverage in the Medicaid program, which, while it certainly benefits hospitals in terms of providing coverage to those folks, benefits the community more generally. Physician offices, are benefited. The community in general is benefited by providing people access to that coverage, and yet we build nearly $700 million into rates for a whole range of programs, the Maryland Health Insurance Program and so forth, until very recently on the Maryland Health Insurance Program. So I think the point that Mike was trying to make here is government wasn't stepping forward, hasn't stepped forward in these communities for many, many years, not just in Baltimore City, but throughout the state, with the kinds of investment and training programs and education, community outreach that we're suggesting. Hospitals perhaps are most effective with these kinds of, more effective with these kinds of programs, but to simply say rely on someone else to step forward when they've demonstrated an unwillingness to do that for many years, I think, is just being a little too optimistic. These hospitals have stepped forward with this program. We're trying to find a way to fund that opportunity using a system that has been a process that's been used previously, and then secondly, to allow for an effective evaluation of the outcomes of this program to make sure that it demonstrates success, or it should be discontinued.
Yes, thank you, Donna. So just to speak to the specific point about whether hospitals are the right place to make these investments, the shift in commerce in the region, from manufacturing to service, has gone over several decades, and we know now that hospitals are the largest employers in their community. These systems, Hopkins, but other hospitals and other systems have made tremendous investments over decades in infrastructure to help their employees learn and grow and to create opportunities for careers, not just jobs. And so proposing to have this done through the Department of Health and Mental Hygiene and public health offices, I think, is one way to look at it. But I think it's hard to argue that the infrastructure that exists in these big systems and hospitals would not be a more appropriate place to train a workforce once the funds are released, and to help assure that these folks are working in these positions a year from now, in new positions 3 years from now, and perhaps helping to bring their families out of poverty over the next 5 to 10 years.
So, and I do want to get back into some of the detailed questions, but go.
Yeah, I just wanted to respond to some of the comments, and particularly, the discussion that Ray and Mike had. I think we all want to do the right thing. We want to find other sources of money for infrastructure, for social needs, and improving communities, not just in Baltimore, but around the state. But one of the kind of the overarching things that I look at is the fact that one of the reasons there's not this level of funding from government, from other sectors of the economy, is because in this country, healthcare is too big. And healthcare, it's great that hospitals and healthcare organizations are engines of economic growth and they hire a lot of people, but as the economists in the room will realize, there's an opportunity cost associated with that, which is that the healthcare sector does tend to suck resources out of government, out of other sectors of the economy, and that is a dynamic, an overarching dynamic that exists here. I've seen studies to show that excess healthcare growth, although it does create jobs, it results in a reduction of 1.2 job for every job created in the health sector in other sectors. So there's that opportunity cost. So I guess my point is, you are doing the right thing, which is going into this demonstration, looking to respond to the incentives of the demonstration, and reducing waste in the healthcare sector, in the hospital sector, because that will free up resources from other sectors to invest in infrastructure along the lines of what you're talking about. The last point that I'll make is that it really is not in the purview of the HSCRC to be a job creator for the state, as much as we would want to be able to do that. It's in the purview more of the Department of Labor, the legislature, to raise taxes to fund these types of activities. But again, they're not able to do that because the resources are being excessively devoted to healthcare.
Michelle?
Good morning. I kind of read the paper when I was reading it a little bit differently, and did see an opportunity to connect the dots for GBR and the purposes of GBR with a social experiment like this. In that sense, looking at the fact that hospitals are going through a expansion of services that are outside the walls of the hospitals. And in doing so, there's going to be a terrific training effort. And one thought, as I think all the comments that have been made here today have been excellent. They sort of represent the optimists and the pessimists, and maybe it's an aggressive program, and it may be working under the best of best cases, but I do think it may have an opportunity to take training to a different level of individuals. Maybe they're already existing in the hospitals that would also move into these community bases and create opportunity then in the vacancies that are at hospitals for some of these entry-level job positions. Having said all that, probably the biggest concern that I have, which has already been raised, is with what Ann said, is taking folks that do not have adequate training and putting them in positions where they could be misconstrued in terms of that support. And then I believe that just looking at how well they're capable of maintaining the jobs and, retraining individuals. I know that I did hear what one of the CEOs had said about the difficulty that it was to keep participants in the program because the dollars they received was almost equal to the state aid, and therefore they dropped out of the programs. So if you had a lot of dropout rate in the program, then it wouldn't have served the purpose that I think it was trying to serve. So I just wanted to make those points. I do think you could connect the dots a little differently than a job expansion program.
So I think we certainly have heard from folks generally, and a lot of the questions that are here have been addressed in general, but we might like to at least talk about a few of the areas, and then we may think about how we want to process getting additional comments on these questions. But I guess before going back to the issue about the HSCRC's mandate or authority, which is certainly certainly an overarching issue, I guess one of the questions that is fundamental is kind of the return, and Mike was addressing the questions about the return on investment. And I guess a question is, are the jobs that are being outlined in here, do the hospitals need the work that's covered by the jobs? I mean, that's a question that we had from reading the paper, and Steve, maybe you can answer that. Are these jobs that the hospitals need, or what is the answer to that general question? I mean, I hear Dave on one hand talking about leanness on one side, and then we're asking for more jobs. So are these jobs that are needed by the hospitals?
Thank you for asking. I think we would argue that these are the exact jobs that are needed, not just by the hospitals, but by the community in order to improve healthcare outcomes. We've been working in a CMMI grant that invested in these types of workers, and have seen success anecdotally and outcomes-wise in how the community has viewed their relationship with healthcare, and how they've been able to step up and create an infrastructure to support, block by block, community by community, improved healthcare outcomes. So these aren't the traditional types of jobs necessarily that hospitals would be seeking, the core programs that are being proposed, but the very jobs now that we think are needed for communities to thrive.
So in terms of the CMMI grant, and you said you have anecdotal information about return. I mean, what kind of return on investment, what kind of savings or return on investment are you seeing, and does that create a funding mechanism? And then I guess how does it relate back to the infrastructure money that's been put in rates? So just trying to create that relationship of infrastructure funding's been put in the rates of all the hospitals to help with transformation. How do these things relate to each other?
Well, just as is being proposed here, this is a demonstration that has a rigorous evaluation attached to it. The CMMI grant also had a rigorous evaluation attached to it, and we've been trying to evaluate those impacts that were made by the investment in community outreach workers and health navigators, for example. But that grant is ending, right? So the question is sustainability. If it's the right thing to do, how do we create a sustainable model to recreate that, not just sustain it at Hopkins, but just to recreate it in zip codes? And in fact, there are very many more zip codes outside of the primary Hopkins catchment area that would benefit from this program than just Hopkins. The sense here is that innovation requires risk, and we're asking the Commission to make that sustainable investment. So to the point about using the benefits that have occurred in reduced ED visits, for example, as a way to fund the program, but that's what we're trying to do from the perspective of the waiver to begin with, which is to try to reduce unnecessary care and waste in the system, and that's what the system originally was set up to do. The system wasn't set up to necessarily add to the workforce, as has been said by several around the table. So we think a parallel process to enhance what the Commission's already set out to do through rate structure.
And do you have a thought process on how this relates to the money that is set in motion already for the January time frame, the 0.25%, or the existing funding that's in rate, that was already put in rates? How does that relate to your current community health worker program or to an expansion? And what about the other jobs? Because there were a lot of jobs listed in the paper. We had, wasn't just community health workers, we had also lots of hospital jobs, laundry and linen, cafeteria, dietary, housekeeping. I'm just trying to understand how they all relate to whether they're needed jobs or they're extra positions that are being created.
I'd be happy to share the floor with other colleagues. I'm not a payment reform expert. I'm a physician. I do have Stuart here, who certainly could comment about the specifics of the funding and the 0.25% and how this fits into that in a moment. To the question specifically about the types of jobs, when we're creating jobs for people who are traditionally undereducated, we have a limited amount of positions that we're able to try to move forward. And as we've, as a system, tried to reduce our infrastructure, as has been said here, again, this is a jobs opportunity that meets the needs of needy communities, and so so there are limited amounts of types of positions that that would be available to that workforce. But Stuart, I wonder if you have comments on that 0.25.
You want to come up? You need to come up and sit at a microphone, so please, so folks on the phone can hear. Thanks, Stuart.
Thanks, Donna. Just to make it clear, and from the hospitals, collective hospitals perspective, we budget for all these named sources of funds. We know about what the HSCRC has approved. We have budgets already for FY16. They clearly have jobs and some new jobs in those budgets. We were looking, given the situation, particularly in Baltimore City, but also, Ray, across the state. We understand this isn't just Baltimore City, but that's where we did have civil problems in Baltimore City. And to be mindful of that and say, what is there a role hospitals could play in that? We're literally talking about, if we were successful, 0.25% of our statewide budget being put into 1,000 new jobs. So these jobs are not in any budgets, any plans. If we were successful, this money would hire 1,000 new jobs. And yeah, there are ways we could employ those people, we think, to be productive and to over time, but I think it's going to be over not a year, but over an extended time to really have an impact on community health. These jobs will be targeted, like we said in our proposal, to very poor neighborhoods, wherever those neighborhoods are, and to where there's high unemployment. We have programs like this at Hopkins. We already do things in those kind of neighborhoods. I'm personally involved in one of them that employ people from disadvantaged backgrounds and different disadvantaged neighborhoods. And what I will tell you is it's tough sledding. It's hard to do. You have to stick at it. It can be done, but that's why it takes a while to get savings out of these things. If we're really interested in making a difference, we sized it at 1,000 jobs because we thought 1,000 jobs would make a difference. I mean, we won't know. It would make a difference in the community, make a difference in the hope in Baltimore City. That may not be right. It may be too small. I don't know. We look at this as for 0.25% Is it worth the chance to say we could add 1,000 jobs? And hospitals are uniquely positioned to be able to handle that kind of population and to get productive work out of a workforce coming out of these communities. We know at Hopkins over the years, some of those people, not all of them, but are very productive, and they even move up in our employment ranks to be supervisors, to move into other jobs, to get education. So we think this can work. We think it's tough sledding. I don't think there's any absolute immediate savings like the first year. I think we ought to really have, as Steve said earlier, a group, an objective group that monitors this and says, you know, first of all, were we even successful in hiring the people? That's the first challenge in these communities. Can you really even attract the people and hire them? and then after training, what was the benefit? We also know that we would try to employ these new employees in the neighborhoods they came from to the best we could because they're familiar with them, and we know that there's an absolute connection between poverty and healthcare costs. So to the extent people living in those neighborhoods, we're not in poverty now, and also we're trying to train people in their own neighborhoods in terms of health education and health wellness, we think there could be significant savings over time. Can you put an absolute number on that right now? I think it would be like a guess if we did it, but I think it's there after all our experience at Hopkins and how we have gone about it. And we could expand this. I mean, I think this is something that's worth a try and should be monitored. There's no doubt about this. It should be monitored very closely and should be decisions made in the future of it. Is it effective or not? These would be hospital employees doing hospital-type work. So we think they're clearly under the mandate of the HSCRC. We think there's no question about that if we all decide that we want to fund it. But the idea of having 1,000 new jobs, I can guarantee you, will not happen without funding those 1,000 new jobs. The jobs in our job base are funded. We know what those funds are, and we're all using them right now. We're all planning on using them. So this is talking about new jobs, and it definitely requires new funding. We've looked at it, and anybody can, and we did not do a tremendously detailed analysis, but we think for any major payer in the state, it wouldn't cost more than $4 million for their share of $40 million. And that excludes the Medicare program. We were looking at just payers in the state, not the federal program. But we think if you looked at it logically, somewhere in the $4 million range would be the max. Most payers would pay less than that. So is this worth to try to address a situation in Baltimore City if we all chip in a bit? We do have training programs that will do this. Those training programs and monitoring programs internally would have to be embellished. This would be a serious new challenge. So that's where hospital management thinks we would put the skin in the game, we would put the management processes in place. And like I told you, it's not easy. I mean, we're willing to do it. I know Hopkins Health System is willing to do it, and it's just a matter of do we think we want to commit some of our funds towards this? I'll stop.
Now, Stuart, do you all have an opinion about whether it should be taken out of the .25 funding, or some portion of it taken out of the .25 funding that's going into effect in January? Is it consistent with the money that's already teed up?
Well, our position on it is we know about that funding. I can tell you in the Hopkins budgets, we know we have to apply for those funds, but we've already budgeted for that. So to say we think that the 1,000 new jobs are over and above the .25 funding, that's how we approached it from our own health system. We're counting, to the extent if we're successful in getting these grants, we already have that kind of thing baked into our thinking. So that's how we approached it. Like I said, hospitals account for all the sources of funds that are available to them, especially through the HSCRC. So I say if you need 1,000 new jobs, you need the funding for the 1,000 new jobs.
And so you're saying that you think there is an ROI, but it's not year one. You don't know exactly when it is. So would you, if you funded them, would you retract the money out of rates over time, and what period of time would you take it back out of rates as an ROI?
Well, my take on it is that we should set up an evaluation process. I think it's definitely not there the first year. We'll never hire 1,000 people in the first year. This is hard to do. I don't think we'd hire 1,000 people in the first year, and it would be incremental over the course of the year. So, what's the weighted average of that? We certainly would be our goal if hospitals, Hopkins Health System could not hire 1,000 people. So it would be, what's the commitment collectively of our hospitals in the state, and what do they want to do with it? Like I said, it's hard to do, so some maybe won't participate in doing it. But if we got 1,000 jobs, I personally think we had to have an evaluation process and almost annually decide should money be taken back out of rates because of that. Give it the first year, see how well if after the first year, as Ray said, we're not successful, it didn't work, it ought to be ended. I mean, if we haven't hired a significant amount of jobs, and hospitals are not participating, then, it might be that we ought to, look at it. But I think it ought to be basically an annual process, at least for the first 3 years or so. See how it's going. Maybe if we see ROI, if we see reductions in those neighborhoods, which I clearly believe we would, but I think it would take years, maybe 2 years, maybe 3 years. First of all, even when you change population health, like many of us know, you're changing behavior of people, and that takes some time. That, even if you're really good at it, it takes a little time. That just because we introduce new workers doesn't mean things change really quickly. So I think even if we're really successful, this takes a couple of years, maybe 3 years, and then in poorer populations, we could see differences in their utilization of health services. That could be a measure of success and a measure of how much money should we keep or take out of rates. I also think if we make this too tight, a lot of hospitals won't want to do it. So if our goal is to create 1,000 jobs, that ought to be our goal, and we ought to have an oversight process, maybe many people in this room, and develop the evaluation process. And that's all I can tell you. I don't think you can target a number, Donna, like right now. I think it's hard.
And so with the goal of 1,000 jobs, then how does that relate back to the Commission's mandate? Is it to reduce costs? Is it creating 1,000 jobs with the focus of reducing costs? How does it relate to our mandate as the Health Services Cost Review Commission?
I don't actually know if you have a mandate to reduce costs, but you certainly have a mandate to have fair costs and right costs. And I think this is services that are needed, particularly in the communities. And like I said, I think there's a high expectation that it will be successful in controlling population health type costs. That ought to be our goal, in my opinion. And we ought to see if it works. And it can have time limits put on it. It doesn't have to be once we grant this in rates that it would never be examined again. That's not. I don't think that's what anyone's saying. So. So you
think the focus is on reducing costs by creating population health?
In the long run, yes.
Focusing on population health jobs.
Right.
And reducing costs.
And reducing the costs, correct. But over. To be clear, over years of time, not in short-run periods, right? And I think that cost will be reduced gradually. I don't think it'll be a cliff kind of effect. Like I said, you're trying to change the behavior of people, and that takes time. And
no, and I guess just one of the other questions, just to ask you, since you're up at the table, about the contributions from others besides payers, effectively. I know that Steve has said that the hospitals think that they're investing by expanding the training programs, but are there other hospital funds that are available to support the program? I mean, what is your thought process on that, Stuart or Mike?
Yeah, a couple of comments. First, I think we neglect to remember that hospitals are employers in these communities. And so to the extent that this is an added cost to the hospitals, they'll be picking up their share of that. They're committed to this. So I want to make sure it's understood, you know, we're employers just like the other folks who will be picking up a portion of this tab. But I think the point that Stuart has raised is part of this evaluation process is to demonstrate that over the course of time, as we hire folks in communities where they may be not only unemployed but uninsured, and provide them with not only a good paying job but benefits, and I believe benefits that won't be putting them back on the Medicaid rolls, but in fact in some cases taking them off the Medicaid rolls, over the course of time there might be a reduced cost to the state for making this investment by providing folks with private health insurance coverage through the employment that they receive as opposed to having them on the Medicaid rolls. So you may be able to demonstrate over the course of time that this is actually a savings to the state. Again, as Stuart has said, you're not going to see that in day one, but you set up an evaluation process to say, what benefits did these folks get? Were they previously uninsured or on the Medicaid rolls? Those are things that you can demonstrate and calculate when you do the evaluation over a period of time to see whether in fact it's actually a savings to the state and which meets the Commission's commitment to reduce costs, and that over the course of time hopefully you demonstrate the improvements in population health. We're doing that now in the reports that the hospitals are required to make or required to submit by the end of September on the infrastructure funding that they've already received. Now, preliminarily, the information that we've gotten from our hospitals is that the amounts that they actually invested in the range of these infrastructure or population health improvement efforts far exceeded the amount of funding they received in rates. Whether they received and demonstrated in these reports the outcomes in terms of improvements in population health, reductions in readmissions, other factors, those are things to be demonstrated and documented in those reports. And I think not just in this first report, but in succeeding years, hospitals will continue to demonstrate. Now that's my hope. I have not seen the final reports. Those were just due the end of September. But I'm suggesting I think the process you put in place for this program would be very similar to that what you've done for the infrastructure investments that have already been made, where you would have the funding that was provided identified, where you'd have what hospitals actually spent on those jobs demonstrated, and then over the course of time you would demonstrate what the outcomes were, whether it's reduction in the Medicaid rolls, whether it's improvements in population health from the folks that are out in the community, and the range of options that are being provided. Barbara, I think this is an opportunity, for example, where many of these workers are supporting what the physician's offices are trying to do in extending their hours and doing the kind of outreach you need to do under the efforts to improve on population health, reduce avoidable admissions and readmissions to hospitals, all the things we're trying to do under the waiver. That's one of the types of jobs, but there are others. One of the things these folks can do is, as indicated here, certified application counselors. Those folks, you can clearly demonstrate how many folks they enroll and whether they're taking people, either getting them from uninsured to Medicaid, or, as we said, when they're employed off of Medicaid and onto private health insurance.
One other thing that shouldn't be lost on us that's pretty simple is they'll become taxpayers. I mean, they will have jobs, they will pay income tax, they will pay other taxes, actually, because they'll have money to spend. So I don't think that should be lost on us. This takes a person from a very dire situation and gives them a fairly good job and is sort of productive in every way, even in terms of paying taxes, probably.
I mean, and there's questions about how would you actually make sure that you were actually increasing employment and you weren't just moving somebody from one job to another. I mean, how would you actually, I mean, we don't necessarily have to solve all problems sitting here today, but, I mean, do you look at how many jobs, you know, Hopkins had at the beginning of the year and how many they had at the end of the year, and are there really 1,000 more jobs there? Or how do you know that there really are more jobs, and how do you make sure that the people who are getting the jobs were actually unemployed before? So how do you start to address those things? And again, we don't have to get far in the weeds, but how do you make sure you're actually increasing employment and not just moving?
I do think we have the data to do that. Of course, we know every single employee on our payroll, so all of us. So I do think I'm not here to solve that problem either, honestly, today, but I do think that's doable. And the criteria, we especially wanted to work with the HSCRC staff to identify. We suggested criteria that would identify zip codes. If that's not okay, we could certainly work through that with any group or the HSCRC staff. But I think clearly the one criteria would be that a person was hired from that zip code. I don't even necessarily know if it means they had to be unemployed. I mean, we could, but these are poverty zip codes, high unemployment. We could talk through those issues, but I think the first criteria for me would be they came out of that zip code. It's the targeted zip code. Now, how do we account for them in our records? And I clearly mean 1,000 new jobs. So yeah, we would have to, Donna, have controls and checks that we're not hiring a replacement job. To me, that's not what we're trying to do. So, but I think that's solvable.
In some of these traditional jobs, whether it's a dietary worker or a housekeeper, I mean, how do you say that it's not just a replacement job ultimately? Well, because
I think they're the easy.
Efficient operation.
I think they're the easy ones. I mean, it's if you had 100 dietary jobs and you don't have 110, you didn't hire 10 extra people. I mean, some of them are easy. Some of them are not that easy, in my opinion. I mean, these are incremental jobs, David.
But what happens if you're in phase or inning 7 of a 9-inning game, and as far as reducing costs in the dietary area? So you've got more efficiencies you can gain through whatever initiatives. How do you know that that hasn't just been a replacement job? I might be at 50 workers at the end of the year, and I started at 50 workers because I put a new system in place.
I didn't think the purpose of this was to add just jobs to add jobs, but to move jobs into areas that are unserved right now, like mostly the population health jobs.
But it is.
So that's why I would think that you wouldn't want 110 at the end of the day. You might want more mix of the change of zip code at the end of the day through a training program. But you're looking at, I think, some of the outreach that the hospitals currently don't have.
I was reacting to the jobs that are dietary and housekeeping and those
I think that's
jobs.
where the action's at.
I mean, I think there are details we would need to honestly address. But to talk about what Michelle just said, I do think we're talking about incremental jobs because we're talking about improving the job base in these disadvantaged neighborhoods. So I guess that's debatable. But in my way of thinking, a replacement job is cost that's already covered by our rates. So to the extent we're doing replacement jobs, I don't think we all need to be here, to be quite honest with you. We were really thinking about, can we make a difference in terms of raising the job base? And I'll be honest, particularly in Baltimore City, but it could be anywhere in the state where this situation occurs. That's what I think we were really talking about here and what the initiative was. And yes, it was sparked by the civil unrest in Baltimore City, and what could we do about it? And could we be helpful? So I look at it like if you're replacing a job, we all do that all the time, and I think we probably have adequate rates for that. So.
I think, Mike, the question that I was asking earlier was relative to whether, in a number of programs that are put out there, the social programs, there's matching, and so somebody's looking to match a contribution. So if there were money put into a program, would it be reasonable to expect the hospital to match the contribution either from their own funds or from some other fundraising source? And I guess that was a question that was asked here, and I wonder what your thought, either of your thoughts, would be on the matching concept.
Again, that's an option for every hospital that wants to participate in this program to consider, and it's up to.
Well, it might not be an option. I mean, if it were a program design, it might not be an option. So I'm just saying,
if you make it a mandate, then it's still up to the individual hospitals to determine whether they have the budgeted resources to provide that matching funds, whether it's from other sources of operations or from some funds that they've raised, other sources of funds, to determine whether they can, within their budget, provide that matching money and whether they then can afford to participate. This is a voluntary program. It's not a mandatory program. Only those hospitals that are willing to make the effort in those communities and these zip codes that have the high poverty and high unemployment and are willing to go through the effort, this Stuart said, this is not easy work, are going to participate in this program. And to the extent that they can identify some matching resources, that is certainly up to the individual hospitals if that's what the commission mandates. At this point, we haven't identified that, so I can't respond other than to say it's a voluntary program and it's up to the individual hospitals and their budgets.
But it's voluntary to participate, but everybody pays the cost. To the extent that you have a limitation on how much you can grow healthcare costs because of the waiver, everybody ends up indirectly putting the cost associated with this because it's all one pot of money, let's face it. We only have a certain amount of money we can spend as long as it's in the rate base. So it's voluntary as far as participation, but everybody pays the cost of it.
If I might add a comment, I have to agree with Michelle to a large degree. The Commission has put more risk on hospitals than ever before in this population health per capita management, which has required hospitals, through the investment reports that have been submitted, to look at recruiting and hiring physicians and working in ways outside the hospital that they have never done before. Outpatient care managers could be home companions. There are a whole list of jobs that conceivably are important for hospitals to do today that were not before. I mean, 5 years ago, if you reduced emergency room visits and admissions, you were going in the wrong direction. Face it, that's what we want to do today. So in order to do that, you need to get up close and personal and treat patients in their home, patients with multiple chronic diseases. And the way to do that is not in the emergency room, but in their home, and to have them eat healthy and so on. And I think if we wanted to draw a correlation between this program that is before you today and population health management, it would be to create jobs in areas that are furthering our population health management in our communities. And Bob, I would submit to you that that is necessary. It's not, I heard you with the 1.2 to 1. I've read that as before, but if we're reducing the total cost of health care by pulling unnecessary care out of the hospitals while we're creating these jobs, perhaps there's a gain there that we can measure. I think Stuart's right. It takes a long time to measure this. We're changing culture. We're changing approach. We're changing end-of-life care, and so on. And I think that as a society, we've got to think of new ways to measure care in different venues than we have before.
So if I could just respond to that, though, why necessarily employment? I think there are other things that this money, resources are limited. There are other things, activities that this type of money, if it's mandated that it's spent, could be invested in that would do a better job of improving population health. More investment in primary care activities. Investment in transportation for people in the city to get access to care. Better nutrition, availability of fruits, fresh fruits and vegetables in inner city areas or in other parts of the state where there's poverty. I don't know that there's been enough work on a direct link between employment and improved health care for people who are investing in this to feel comfortable that their investments will actually merit a return on investment. Also, particularly when we're talking about entry-level jobs, I don't see the return on investment for funding those types of positions. There may be one associated with some of these other positions, but that hasn't also been established.
I would just like to add to Ray's piece, I would be concerned if we were going from 100 housekeepers to 110 housekeepers at the end of the day, because we do have this mandate to be efficient hospitals. And so just to the things that you were speaking about, Bob, there's, a hospital in Kansas City that the CEO did all of those things. It was a real changing process, the transportation, the farmers market in the communities, traveling actually through the communities. It was the hospitals that did that. So I think, to my point, is not the infrastructure of running your inpatient units, but what are you doing to get out in the community? And Hopkins Bridges program is a perfect example of what we've been doing, educating lay community members. What could we do if we had paid physicians that actually worked and could do more with that? Did more in the public schools. There's just a lot that could be done, and it's the vehicle. In many ways, you can say, should the hospitals do this? But if population health is becoming more a mandate of the hospitals, and that's the direction it will go, then maybe we need to think about that.
I would just add that the types of functions that you're describing are not the base level, entry level, high school equivalency or high school education that this jobs program is really talking about. It's much more sophisticated worker with a lot better training and certification and supervision.
I just want to ask the question of, if we look out 3 to 5 years down the road, how will we judge success of the program? Will we judge the program if it's implemented? Will we judge it successful if we've merely hired 1,000 new people? Or will we judge it successful because we are actually improving health in the communities, we're helping reduce cost, and we're also employing people that were not previously employed? I would submit that if we're not looking at all 3 of those criteria, I think we're setting up the program in the wrong way. So I think 3 to 5 years from now, if we judge success merely on the fact that we've hired new people, that's not really getting at what we're all around the table to do. We're not here to really just give 1,000 new jobs regardless of what those folks are doing. I don't think that's the intent of anybody here in the room, just to hire new people, but I think we need to be very explicit for this program going in of how we will judge success 3 to 5 years down the road.
And so right now that that hasn't been laid out sufficiently in the proposal as to how we would judge success.
I truly think the intent of everyone who's providing information is to do all 3 of those things. I think the intent is there, but I just think we have to be really careful not to simply frame this as a job creation program. If it's simply hiring people, adding 10 more people in the cafeteria or adding 10 more people to do housekeeping, I just think that gets away from the overall goal, the intent of what we're talking about, which is really improving care, reducing cost, and also employing people in poor communities.
Jim, make one mention that underscores a little bit of what was just shared, but from the perspective of Medicaid, and I think from the perspective of the state budget, I think your ROI comment is extremely important. I think we need to know, Care First, United, you participate, Kaiser, other payers participate in the state employees program. What's the ROI going to be on that side? And then certainly on the Medicaid side, we know that it's $8-ish million impact based on what's here. But I also want to say that I think the statewide-ness is a really critical thing. So 2 years ago, so predates me, in advance of the ACA implementation and the implementation of the Medicaid expansion, the state looked at our care coordination funding that we give to local governments for high-risk pregnant women and other folks who are navigating the managed care world for the first time. When we looked at where we knew the highest number of uninsured and the largest number of new enrollees were going to be, on a percentage basis, they actually weren't in Baltimore City. They were across the state. They were in places like Howard County, Frederick County, Cecil County. So thinking about it from the perspective of where the folks are who might, sort of need these kinds of jobs and where the new Medicaid expansion population might be, I think that's something else that should be on the table if this proposal moves forward.
I think, there was a question asked later in the document about the design. So, I mean, if you were actually thinking about the proposal said to hire from a zip code, but theoretically, couldn't you deploy somebody hired from a zip code anywhere in the state? If you trained them, couldn't they work anywhere in the state? That's a question. Is there any real restriction that they would have to be at Hopkins or West Baltimore? Couldn't somebody who came from zip code X work in Washington County or Howard County or Montgomery County?
If that wasn't clear, that the intention was they can work anywhere. The idea was to help
just to help target them from zip codes. So
there's no intention that they would work in those they might. I also would like to clarify, we didn't try to put an exhaustive list of jobs. Like, I think we tried to give good examples of where people could fit in and where they could in the long-term or medium-term make a difference. We do support the productivity aspect of it. So, I think as hospitals voluntarily applied, they would show the plan to the commission staff and be a judgment of are those jobs that are, something we want to support or not. Like in every, it's almost like any hospital job, if somebody could fit into it and we could think that they would do it. Some of the people in these zip codes, by the way, are unemployed and they're poor, but they do have some educational background and they do have some skills. So it is a mixed bag. It's everybody in a zip code. So you never know when you're dealing with these populations what person would apply for one of these jobs. And I'm sorry, Mike.
So I had a question. So just by that statement, they don't have to work in the area, the zip code. So that's not a community health worker, and then we're expecting them. So we're not
limiting this to community health workers. So.
But training someone in Baltimore City, are they really going to travel to Howard County or Cecil? I don't think. I think we need to be very, Let's be real. I'm a realist, not an optimist or a pessimist. I'm a realist. Let's be real on that one.
As an example, I worked for 9 years at the Greater Baltimore Medical Center. We had hundreds of employees that lived in Baltimore City. In downtown Baltimore City, Greater Baltimore Medical Center is out by the Beltway. They literally came by public transportation to our hospital, and they worked. But we had hundreds of people. So it doesn't mean they have to work where they live. Yeah. Well, they might not now. But like Ray was saying, there may be zip codes that qualify in other areas of the state. I would think those hospitals would work with zip codes that are more closer to them, and not Baltimore City in particular. But Baltimore City workforce really travels to the surrounding counties, for sure.
And I would absolutely say that is absolutely true for the housekeepers and janitors and dietitians and everybody else who works physically in the hospital. They do that. But the very nature and definition of a community health worker or an outreach worker is they live and work in their community, not transport to another community to do it.
I'm not arguing with that. I'm just saying the job base is broader than, it's not just community health workers we're trying to establish. That was an example of a job.
But we were just saying we don't necessarily need to have more housekeepers, janitors, and cooks in hospitals where admissions are supposed and volumes are supposed to be shrinking, and therefore the infrastructure is supposed to be shrinking too.
That's not exactly true, but there are hospitals in the state that have volume increases. So we need to be careful, and that's why we tried to not limit this, that each hospital could apply for their specific situation, and there would be an evaluation process, just like there is now for other programs the HSCRC has. So there could be that there's places that need 10 more housekeepers. I would think there are. That's all I can tell you.
Donna, could I just make a quick comment about the 3 points on return on investment? I agree with David that it has to be broader than just creating jobs. There needs to be some savings. But 2-3 years down the road, I don't know how we attribute savings that are generated globally in the system to this program. I just think that will be extremely difficult, if not impossible to do. I don't know how we would assess that. Also, when we're talking about ROI to the public, it means an actual return in savings to the public. That would mean removing this assessment and then lowering rates even more so that there's a sharing of savings between the public and for any ROI, if it can be determined, and the hospitals as a result of this initiative. If we don't do that, then all of the savings benefit, if they exist, we're down to the benefit of the hospitals, not the public.
Can I ask a question? In the paper, there were some examples of people in your current demonstration program that started in a job and moved up. Is there any way for us to hear from the people who we're actually targeting, for people who have gone through your program, about what helped them, what they see as the barriers, how they live, or what, their view from the ground? Is there any way to hear from them? Either people who have successfully completed your program or the people who are living in the community who might be a target hire? Just an idea.
I guess there is. I mean, we know some of the people, the real people, but we haven't done that yet. I mean, I couldn't tell you that right today. But, I mean, the real people are in our workforce, so if that was important, I imagine we could get some of that data from them, or at least their story. It would be anecdotal of how they feel about it, but there are real people that are in these programs now. So, yeah.
There are also civic organizations that have been partners in trying to build these bridges, and it would be wonderful to include them in the evaluation team. Just for that reason, we should be asking folks what they believe are needed in their communities, and they should be a part of the process of evaluating it. And I think I think this is a great conversation. The issue of whether these investments are made in local communities and whether people move about. We also have tremendous healthcare disparities, and I don't know that it's just about reducing costs, but it's about improving value, and value is that equation of outcomes divided by cost. So if we could improve the ability of people to engage in managing their blood pressure and staying clean from drugs, those kinds of outcomes should be a part of this in a targeted way, and I think we would be able to demonstrate that ROI slightly differently.
So I was just going to kind of take stock of where we are relative to the questions, and I know that we kind of went at it in maybe a little bit of a random way, but I think it actually gets to putting answers out to most of these questions. But let's just take stock and on the general question of, does the proposal relate to HSCRC's mandate authority? I think what I heard is that if it does three things, or if it not only creates jobs but also improves community health and ultimately reduces costs, then that would be the factors that one would need to take into consideration to judge that sort of thing. And more specifically, I think there were a lot of comments about discomfort of the jobs being inside the traditional hospital jobs. There was more comfort in thinking that they would be new jobs related to, or different jobs that would be related to population health and things that weren't inside of the traditional workforce of a hospital. And there were a lot of comments around the types of jobs and the importance to relate them to the prospect of creating a cost reduction. In terms of the value of the jobs, I think we talked about whether the jobs were needed, and I'm not 100% sure where we landed on the answer to that question. I think it depends on what the jobs ultimately are, and how they fit into a long-term program. And I'm just summarizing what I've heard, what I think I've heard so far. In terms of cost and who should bear the cost, I think there were a series of thoughts about whether these programs would be more appropriately put forth inside of other parts of government. Should there be an expectation of a contribution or a matching concept? There's whether the payers should be responsible for funding them, or they should be taken out of the existing infrastructure. So I think there's a variety of opinions that were presented on that topic, from the suggestion that they should all be funded out of the infrastructure that's already there, to we need extra money beyond the infrastructure that's been funded in order to make these jobs happen faster. They might not have the ROI speed of some other things, and therefore we need to fund them separately and the training separately. And then in terms of design, we didn't really drive very deep into the design section. And I guess just maybe just a couple minutes of advice might be helpful there. Before then we can move on to some other topics. But in terms of design, if we were to do a program like this, how should we set up a design process? So if we could get some brief advice on that topic. The HSCRC staff doesn't see itself as experts in creating jobs to jobs program.
If we would decide to recommend this, and especially if the commissioners would decide to approve it, but I would see in general that it certainly would be a voluntary program. Hospitals would voluntarily apply for it. Commission, would approve it and put it in rates. And then there definitely needs to be, like many people suggested, an oversight group or committee, and probably should be a group somewhat similar to this. Maybe I would suggest smaller, but that had all the stakeholders on it, and at least in the beginning would have the concepts, which we've talked about, of what measures of success are we looking for. I think, like we do in many things, more technical groups could get together then to say, how do you, if these are the three things we want to measure, how do we really physically do it in our record keeping, and and what are the challenges there? And secondly, I think there could be a group that immediately got together, a technical group that says, what are the details? We did outline some of the details of what should be included in the application process. Certainly that could use more meat on the bones, but we tried to put the framework of what would a hospital have to describe to the commission staff to even that their application would be considered. So the framework's there, but I do agree that we should have a technical group maybe to answer a little bit more the detailed questions. We didn't try to get that deep, sort of intentionally, and certainly the HSCRC staff would, in my opinion, lead that process, but have a technical group to develop it. And I don't know if that's enough, Donna, but that was generally how we thought about it, and it's worked in the past for things we've done. It's a similar process.
I mean, would you think that the AHEC should run it? Because I mean, I was just thinking, in the nursing support programs, the nursing schools are really fundamental in the design processes. I mean, have you, if you were doing it, would you put the AHECs in charge of designing it, or do you think it can be effectively run through hospital training programs?
I don't know enough, me personally, about that to answer that right this minute. I don't know if anybody else does, but
no advice yet. So.
Well, I can
So
only
TBD.
tell you
No, that's good. It's TBD.
Is that good enough? No
yeah,
advice.
that's good enough. Good enough, Stuart.
Thank you.
Any other closing comments before we move on to another topic?
Just very briefly on the design side, I mean, I think just based on this discussion, it's clear that there's just a lack of detail in this proposal. So I would recommend that the hospitals go back and try to spend some more time on addressing some of the issues that have been raised here, such as that provide clear and convincing evidence that there is a strong link between improved employment and improved health care relative to other types of activities that could be funded, like providing a lot of money for primary care. I also would suggest that we have more discussion about the types of positions and the issues related to training. I think, yes, there are probably many capable people in the city that could perform some of these jobs that have been mentioned, the community health workers and so on, but that will likely require a fairly significant training commitment. So what does that look like? How long are they trained? Are they paid while they're being trained? I mean, people aren't going to just come in and take this training without some type of support, some type of financial support. So those types of issues haven't been addressed. Also, questions related to the funds flow associated with this. We talked about workers could be employed by other hospitals. Well, are they in the city? If they're not in the city, are their rates going to be raised associated with this so they could pay these workers? There's just a number of issues that have not been addressed that I think it could be thought through, not necessarily by a technical group or by the HSCRC staff, but by the folks that are proposing them. So that's what I would recommend.
Well, Bob, I think hospitals are uniquely positioned to do this. We know we can do this. We already do it. I do agree with your comment on how do you measure the success of it, basically, but that's not a design problem. That's a measurement problem. Like, that's how do you measure the success of the program? We're clearly committed to that. We're not trying to walk away from that, and we definitely think that needs to be done. We do this today, so we can do this. It's just the magnitude of it. We can't support 1,000 new jobs if we think that's what's necessary to bring hope to some of these neighborhoods that have clearly had civil problems. So it's a matter of do we want to do it or not, and I'll guarantee you every barrier we put up, do you have to put some money in, do you have to do something else to hospitals, it'll just be less hospitals that participate. So however successful we would like this to be, if we think 1,000 jobs is right, if we do, I think we should encourage that, and then we should measure it like crazy. The simple measurement to me would be look at it in 6 or 12 months and say how many people were hired. I mean, if there's 40 people hired, we weren't really too successful. If there's 400, maybe we say, hey, this thing's moving in the right direction, and let's monitor it and let's watch it for a couple of years. And it's not a gigantic investment. It's 1/4%. So it's a matter of what we want to do. I mean, we can kill this thing. There won't be 1,000 new jobs, I'll guarantee you. Everything you've already granted in rates is committed in budgets. So those jobs will be hired. 1,000 other ones will not. So it's a matter of what we want to do with this process.
Just to be clear, we're not against reducing, efforts that don't expand employment. We certainly are, but we think that there may be other ways of doing that. And one in particular is to right-size the healthcare industry so that it's not pulling in resources from so many other sectors, including government.
Did you want to say something?
Yeah, I have to say that I was, I've been wondering why this group even has this issue before it. And let me say I'm all for creating jobs in areas where clearly those jobs are needed. I'm not sure this is the right mechanism to do that. But if we do this, then I think it behooves us to require all the things that Stuart described about in the applications for participation in this program. And I think we need to look at it, if this is going to be an HSCRC thing, we need to look at it not as a job, we can't ignore that it's a job creation program, but we need to look at it from the perspective of what it does for the effectiveness of the Maryland healthcare system in achieving the goals of the program that the waiver program that we're engaged in, particularly in population health. It's interesting that nobody's mentioned here. I mean, everybody knows that we need jobs in a lot of areas in the state. It occurs to me that those areas also are the areas that probably present the biggest challenge in terms of population health and the ultimate goals of the waiver. And I think that that ought to be the focus of this process if it's going to go through HSCRC, that the hospitals want to participate in this program need to demonstrate how the availability of these extra jobs is going to help them either through the direct use of those people or the ability to free up other resources that are going to be able to address community health. How those that money is going to be able to be used to achieve the goals of the waiver program that we're engaged in, because otherwise, you know, you would be much more efficient to have the legislature, you know, appropriate $40 million to hire people in this area. So we need to connect it very firmly to the objectives of HSCRC if this is going to happen through HSCRC.
And I would add, too, that if you're looking at places to start in terms of looking at what types of work and evaluation should be done, the state in the last couple of years has funded studies with the University of Maryland, Baltimore, the health professional schools, nursing, medicine, social work, to look specifically at the role of community health worker, what they do, and how to evaluate their success or failure. So that's a very good starting point as opposed to kind of stabbing in the dark. For what I see are potentially maybe 3 jobs on this list that would be true community jobs. The rest are basically hospital jobs. So for the community jobs, look at what's already been done in work in terms of looking at community health workers.
One additional way I said, you know, and when we ask people to explain how they're going to do this, I mean, the way these jobs are used may well, and in fact probably will, vary by the community in which these programs occur. So each hospital, I think, needs, rather than having an overarching thing, each hospital needs to describe how exactly it's going to use these resources to achieve its goals.
Okay. Well, I think we have got a lot of input here, and we'll be taking a crack at synthesizing it, and taking it into account in terms of communicating back with the commission. So with that, I'm going to move on to our next topic, which is the market shift update. Thank you all.
All right, so we thought it would be good timing in terms of giving you an update on the market shift calculations and adjustments that we've been working in the last year. As you may recall, after high-level discussions with this group, we took the details, technical details, to a subgroup and worked with the hospitals and other stakeholders to really dig deep into the data. Briefly, the market shift adjustments, the main principles are not to undermine incentives to reduce avoidable utilization in the hospitals, but at the same time provide necessary resources if the services were shifting between hospitals. So taking those 2 main goals of the overall hour demonstration, we created 66 in total different service lines and looked at the trends within each service line in a very small geographies, zip codes in particular, and we also consolidated the rural areas where the population numbers weren't big enough for us to do this reliably. So we aggregated the zip codes in the rural areas. In addition to the service line algorithms, we excluded readmissions and potentially avoidable utilization, PQIs, from these algorithms, so we are not adjusting hospitals for these two categories. And in looking at these shifts, once we calculated utilization changes, then the adjustments were done at the hospital level. So hospital cost still determined how much money hospitals will receive or lose based on their own individual unit costs. And we even further adjusted that at the service line level. So if the hospital had lower average costs for orthopedic surgery and they were gaining more resources, then their cost was determined by the orthopedic surgery average cost for that particular hospital. And also, in line with the other GBR policies, we use the 50% variable cost factor. And as you recall, we are trying to give the resources needed for these additional services provided at the hospital, with the idea that the fixed costs are already covered under GBRs. Going back to the discussions on market share versus market shift, the adjustments are done for differential changes. So in the first example, what you have is two hospitals with, let's say, 50 admissions in the first year. So they have an equal 50% of the market share. And with the changes, as you see, Hospital A increased their market share to 250 versus 100. In this example, both hospitals have utilization increases, and our algorithm is not going to make any adjustments because it's really hard for us to determine what the shifts are if both hospitals have a similar trend. So similarly, if the both hospital have declining trends, again, we are not making any adjustment. One, not to undermine the incentives to reduce utilization, but two, it is really difficult to judge what the shifts are underlying under those very similar trends. So what the adjustments are doing is it requires that in a zip code, particular zip code and service line, there has to be a differential changes. So one hospital going up, another hospital going down, for us to be giving adjustments to the hospital. So the idea here is we are assuming that the increases are happening from reductions in another hospital. And in order to still protect the hospitals who are reducing their utilization, we limit the adjustments to the lowest of the two. So if in this example, you have the hospital B reducing 25 cases, but the other hospitals increases 200. So the adjustment here is limited to 25 because that's what we think shifted from Hospital B to Hospital A. And conversely, if Hospital B really reduced much more than what the other hospital gained, then they are still keeping the additional reductions that they have in their budget. We work with the hospitals. We provided the data late spring, patient-level data, and also the service line reports for them to look at it. Especially on the outpatient side, we noticed a lot of data inaccuracy, so we opened our data sets so hospitals resubmitted so we could have inaccurate shifts calculated. With that, the statewide impact, excluding oncology, radiation therapy, and infusion, which I'm going to get to shortly, the statewide net impact of the first-year adjustments is around $750,000 because since we are shifting the utilization from positive to negative, the calculations for the utilization is revenue neutral, zero. The differences are coming from the differential charge adjustments that we make for each hospital. And you see the positive or negative adjustments are around $27 million that we are shifting between the hospitals. Yep.
Expensive hospitals.
Yes.
Okay.
Or more expensive service line / hospital.
Okay.
Yeah.
Right. I wasn't trying to be a purist then. I was just wondering.
Well, I'm not sure I understand that. I'm looking at this chart, and maybe I read it the other way.
Yeah. I'm sorry. Yeah.
The other way they went.
All right. They basically went to cheaper.
Yeah.
The other clarification I wanted to make on this chart, because it says fiscal 16, is this also includes the positive adjustment that went to St. Joe's, It does not.
No, no.
It does include the
It does not.
It does not.
So we didn't do any, this is the calculations results, what we calculated. And then on top of it, the additional adjustments needs to be done for rewarding the St. Joseph adjustment.
Right.
And systems also did some shifting that we had prospectively adjusted on top of it. So this is the impact of the calculations, fewer calculations.
Well, I'm not sure I'm getting my question answered. Is this all adjustments that were made to all hospitals, including St. Joseph's? They had a market shift, positive adjustment, that was advanced to them by the Commission in fiscal 15. So that, in fact, the question I'm asking, isn't the fiscal 16 adjustment more negative than this number? Because they already received a portion of the $27 million positive adjustment in fiscal 15.
Partially, it's included the way we calculated, so it includes St. Joseph, what we calculated, but it doesn't take the net impact of the prospective adjustment we did for the St. Joseph, in addition to other prospective adjustments we did for the hospital.
Okay.
From the hospital perspective, this is, each bar chart is the hospitals, and as a percent of their total revenue, how much impact that we had for each hospital. And as you see, the range is plus and minus 1.5%. So the biggest adjustments that we made is 1.5% of the hospital's total budget. We have a technical documentation, hopefully helpful. We included all the weights, all the calculations, and the technical document that we work with you on the high level, and then also the detail with the subgroup posted on our website. So the only, so the fiscal year 16, if you recall, was based on a 6-month period. So we were looking at July to December time frame. For this coming year, it's going to be a 12-month. Hopefully, ICD-10 is not going to create an issue there. But if not, it's supposed to be a 12-month adjustment. The only adjustment that is left for that 6-month period is the outpatient oncology service lines. The reason why we pulled this oncology out was because of the recycling billing. Some hospitals were submitting 1 record per visit, another was reporting a monthly per record. So it was hard for us to tease out how many visits we would count in these calculations. So to make that adjustment, we aggregated the records at the patient level. So we grouped all the records per patient around the 6 months, and we are working towards creating weights on a patient-based calculation, so we get rid of these issues around hospitals differentially reporting the services. And we had one work group meeting last month on this issue, and then we are meeting again to kind of work through some of the other details on the service line. And I believe the rate orders are going out without this adjustment, but with others included already in, because we won't be able to wait for finalizing the adjustments on this side. And then they will be added to the GBRs once we finish the technical evaluation.
It's 6 months of data, right?
Yeah.
And it's a 50% variable cost factor. So it's really plus or minus 6% volume shift. Am I doing that right? On an annualized basis. You have minus the plus 1.5.
Yep.
50% variable cost, so that's 3, and it's a half a year, so that's 6.
Mm-hmm.
But I was just
I mean,
if
you look at the
Did I do that right? That's a little
3.
Yeah. But I mean, that's I didn't.
If you look at the dollar figure, you know, the dollar figure of the pluses and the minuses. So if you look at 28 million as a percent of gross revenue in the state.
Right, but it's only on 6 months worth of information. So if that would be consistent, it would be close to a $60 million adjustment, and that's at a variable cost factor of 50%.
If it were double that, yes, it would be, yes, it would be 60 million on an annual basis.
I'm just surprised it was that as big as it is. I thought it was going to be a little smaller than that.
Mm-hmm. So that's on an annual basis, that's about, what, about 0.3%? 0.3%, not 6%. So point.
No. On the extremes of the volume. So some hospitals saw as much as 6% volume deterioration related to market shift, and some hospitals saw as much as 6% pickup.
Well, those are, one is St. Joseph on the positive side that has an, a unusual situation, I would say, and the losses are also, we looked at it and is related to St. Joseph picking up a large market shift. So you don't know exactly what's going to happen this year once that relationship settles.
And the other ones are, we also have market shifts in here related to the opening of the Germantown Hospital. So some of the larger shifts in here are for Germantown, at least I'm not even sure that they're all getting into this period. They're more in the next one that we're looking at. But we will see the Germantown impact coming through here too.
Does this include the negotiation that went forth with St. Joe's, where you had shifting among those hospitals?
The St. Joseph adjustments that were already made, and Mike was asking this question earlier, aren't in here. So this doesn't include the increases or the decreases that were already made in advance of this. Although so we're not applying the St. Joseph adjustment out of this number to their rates. Although we are applying the market shift adjustment of the other entities that we took money from in the university system, we are still applying the shifts out of here to their rates. That's another issue. But so it's about, I think there's about a $5 million figure in here that is actually not being applied at this time because all of the money's already been given out up front. That's what Mike was asking earlier. So it's actually an increment of $22 million going into rates, and not $27 million. On the other hand, we also don't have the new Germantown Hospital figures in here. They're excluded from this total, and so they're going up, and so they're excluded from the total.
Yeah, and there are other adjustments that are impacting that net number. Some hospitals have PAU adjustments that they requested from us, that because our PAU adjustments, potentially avoidable, is on the readmission and PQIs, if you recall, and we recognize that hospital may have programs impacting other types of avoidable utilization that we don't take into account, and we are going to be working with those hospitals to tease out those trends and making sure that they are not hampered or negatively impacted by the market shift calculations. In addition to those PAU adjustments, the other factor that we are taking into account is the payer-driven approaches. So it could be that some payers may be encouraging or creating networks to have their patients to go to a lower cost setting, or according to their calculations, a better setting. And there is also some need to do some prospective adjustment in those scenarios where the hospitals may receive additional revenues in recognition to the payer-driven approaches.
So, and actually, I was going to point out that the commission asked us to make a special communication to the hospitals because the commissioners were concerned that some hospitals may be cutting back their efforts because they're concerned that their PAU reductions would be confused with the market shift. And so and Julie just sent out a memo, and you all may not have seen it, and we probably need to really think about how to more broadly distribute it through MHA, not just through finance, but through the executive level. But, encouraging hospitals to, if they think they have a PAU program that goes outside of what we have identified, to notify us in advance of the program and then provide measurement back as the year goes on. So, for example, if a hospital has a program to reduce its ER utilization, that we wouldn't necessarily want somebody else's lack of a program where their ER visits are going up to take money away from the hospital who made investments to reduce the ER utilization, because that's their ROI source to refund the intervention. So the commission said, make sure that you put advice out to ask people to file their programs up front, and then to provide details as they go along, and to identify if they believe that the market shift adjustment is negatively affecting their PAU program or their intervention program, and inappropriately measuring shift. So we are putting out that. We did put out a memo, but I think we need to really focus on getting that out in a different fashion.
Any other questions?
I have one comment, and I don't have I have a request actually. Is if we could go back and revisit in-migration and out-migration along border counties. I don't have any numbers in front of me to quote to you today, but I can tell you that West Virginia University, Mont General, and Morgantown are reaching into Western Maryland. Summit Health and Polyclinic in Harrisburg are reaching down into our area, and they're like buying labs and trying to recruit physicians. I don't know whether that's associated with their ACOs or what it is. I can't really tell. I don't know if that's happening in Delaware, border counties, or anywhere else. But I think it might be a time to revisit what are the incentives around this, and how do we, what do we want to promote or dissuade in terms of these behaviors? Thank you.
Thanks, and it is an issue of concern, and we are just hopefully getting ready to tackle the APCD data, as well as we are getting ready to tackle the Medicare data, so we can look at what's happening with in and out migration.
And also in terms of the PAU adjustments, the infrastructure investment reports that we are collecting, the review committee is going to look at it from that lenses too, to see if there are any emerging programs that are common across the hospitals that we need to expand the PAU definition for next year. All right. So I'm going to move to the next agenda item, to performance workgroup plan update. There is no meeting materials for this topic, but we wanted to inform you that the performance workgroup is also starting their busy schedule with this month. There is the QBR final recommendation in front of the commission this month, and basically increasing the weight on our patient experience scores. We received the exemption from CMMI, but they highlighted, as we all know, our HCAP scores lower than the nation, and our continued lack of progress in improving those scores. So recognizing that, the staff recommended to increase the HCAP's weights from 45% to 50% of the QBR, and the maximum penalty on QBR is 2%. So it is a substantial amount of money is associated with the patient experience scores. And we are continuing to align our program with the CMS value-based purchasing program in terms of the measures and the timelines to implement them. The other programs will be also looked at with the work group, the MHACs, the hospital complications. We finally got our methodology contractor on board, and their first task is to look at PPCs and validate from the statistical point of view the variation we have on the 65 PPCs, and recommend us what to do with the small cell sizes and some of the biases that we've been seeing in the PPC rate. On the readmissions, the task is complex and quite complicated. The work group will be dealing with the issues around socioeconomic adjustment to the readmission rate. And also, right now, our program is on an improvement basis, and if we have inadequate adjustments for border issues and socioeconomic issues, can we implement an attainment type of program where we would reward hospitals if they have lower readmission rates than expected. In addition to the program per se, we are still working with the CMMI to finalize our readmission measure for the target. I know it is an arduous process to get these done, but we are on version 5 now with them. But the good news is it's improving. So every change that they made when we started, it wasn't any adjustment. Then they adjusted for the beneficiary, so they have to be enrolled for 30 days, and that helped us a lot because, as you know, we have a lower mortality compared to the nation. So our patients are in the denominator, whereas in the nation they were out of the denominator, had no readmission rates. We are also working towards adjusting for the swing beds and other things that we have structured differently compared to the nation, and making sure that the assessment's done adequately. And probably there are other things that I'm forgetting right now, but another important one that the performance work group is going to start looking at is the strategic plan. As you know, we had these programs for a while now, and in the new waiver and adjustments and alignment with the physicians and other providers, what do we do for the performance programs in the state? So what does that look like, 2 years from down the line once we have the phase 2 application? So we are hoping that the performance work group is going to help us to think about this and then help us to reform our programs. So and as the issues come up, the finance and the quality, we are trying to get them together. And for the division of labor process, we separated them, but obviously this is a big interest to this group as well. So we are going to be bringing the discussions from the performance work group and taking your discussions and translating them to them as well. And there is some overlapping membership at the subgroup level between the two groups. Any questions on the performance work plan? Yes, they're all, we are in the process of setting those dates, and they will be posted on the website shortly. I think internally we did, but didn't communicate yet. Yeah. All right. Next topic is the efficiency and our approach to look at the efficiency measures. And I think we discussed this with you last year, our approach in general, and the reasons why now it's becoming a more important issue in our timelines. As you can, I just wanted to start the discussion from the high level in terms of the efficiency cost measures and different uses for it, and then making sure that we have a good handle of what we are creating this for. And as you know, the cost is an important factor for many people who are using the healthcare services. From the business perspective, they are looking at their total cost. Consumers would care how much they pay, but we as an HSCRC care more of the efficiency side rather than the actual cost. If you are just calculating for the consumer and publicly reporting for them to pick high efficiency hospitals, the cost side doesn't require a lot of adjustments, because at the end of the day, the question is how much they're going to pay for the services. But when we're evaluating the efficiency of the hospital, obviously we have to take into account the patient mix and other services the hospitals are providing that they should be taking credit for. In terms of our preliminary needs for the efficiency measure, is that we need a measure to evaluate full and partial rate applications. Certificate of need reviews require an efficiency measure. And also, in the CMS value-based purchasing program, they have an efficiency measure that they scale hospitals individually, similar to other performance measures. We've been handling it through our potential avoidable utilization adjustment, and as we develop more advanced measures of efficiency, the one areas to use it could be similar to what the CMS value-based purchasing is doing. And by our contract, we are required to match the CMS value-based purchasing program to the extent as possible. Yeah. So the efficiency domain that they have, they calculate per beneficiary 30-day cost. And similar to what we do with the PPCs, they look at whether hospitals are higher or lower than the national average, and then they get proportional scores for it.
So it's basically an inpatient episode?
Inpatient, well, it is a total cost, actually, both inpatient and outpatient and all other services provided 30 days after a discharge.
Okay. Right, but it's an episode.
They call it per beneficiary, but at the end of the day, when you look at the detail, it's a 30-day total cost episode.
That could fall out as an efficiency if you reduce the readmission charge to off the remaining patients. However, there's a funding mechanism to get that out.
Yeah, I'm gonna right.
Get a bunch of money to your readmission out there. The rates go up.
I guess you could look at both ways. One is adjusting it, right? If it is still in the rates, making sure you don't take that into account. But also, I think the bigger question is the funding mechanism.
Yeah, I think it's ultimately trying to see how you look at on a per capita basis versus a per case basis and figuring out how to balance that.
Yeah, I was reacting to the first email out there.
And I think increasingly, I've seen that the cost public reporting is looking at episode-based. You're looking at a per case. If you don't know what the readmission rate, it is a misleading kind of cost assessment, really. Yeah. Right. Similar to that is as hospitals are doing a better job controlling the population health, we all discuss that the per case cost will go up. So it's kind of similar to the quality adjustments or efficiency adjustment we make, but there is more fundamental issue that we need to grapple with in terms of our per case cost and making sure that the measurement doesn't impact the hospital negatively if they're doing a better job controlling the population health.
Sully, are you looking for different measures like EEGs or not EEGs, CMGs or whatever they are, episodes of care, where you look at a disease entity and you look at the number of patients within that and the total cost of care as opposed to per capita? Are you looking for subsets? Is that where you're going? I'm trying to understand.
Yeah, maybe I set up my opening quite long since I'm going to get there. But so the cost per case is the small dot, and then in between per capita and cost, we think bundle cost or episode-based costs are in the middle. And I think we are looking for an input to see how much you think is worth investing in creating an episode-based measures rather than working on total cost. So there is a timing and resources needed and the direction that we need to take. From the GBR perspective, we think we should move towards total cost and try to come up with a per capita cost to include both utilization and the cost drivers. If you focus on episodes, we are still dealing with the number of episodes questions. At the same time, for our performance measurement and in the strategic discussions we are having, to think about episode cost as a performance measure rather than an efficiency measure. But for example, we could think that the knee surgery bundle of performance measures, one being complication rates, readmission rates for new surgeries, and the cost of a new surgery episode, combined and creating the value proposition or value concept, but based on a particular service line or a procedure. But overall, from the system-wide perspective, we think that as the GBRs are focusing hospitals for avoidable utilization and reducing utilization rate, sooner or later we need the per capita cost measure, and the resources are probably needed on the per capita total cost measure rather than initially focusing on an episode-based measure. David?
Clarify, you're adding it, right? As you move up the curve, we don't lose the measures further back on the curve. We add on top of the measures, right?
But different, right, we are thinking they are not replacing each other. These are different windows to the efficiency, and we do think that there is informational value in looking at all three. Then the question would be which measure that we will ultimately use for the decisions that we are making for the rate applications, CONs, and the VBP.
This probably is an answer that you and I should just have a drink over.
Sure, I'll be happy to.
Okay. As you know, as I look at this chart and with the red dots and the size of the charts, my question is, okay, you know, I'm pretty clear or not clear from, you know, as I'm being educated, how you might have the data to define the you know, the cost per case hospitalization. I'm less clear on the data and information that's involved in the bundled cost, and more unclear on your per capita total cost, where that data comes from, what the measurement is. So that's probably a separate discussion, but that's, you know, how does the HSCRC define those things? What are all the costs that are included when you define those various categories?
That will take more than one drink, Barbara. So yes, I think as we move from hospital to the other services, we need to think about what data available to us, what we include, and we are thinking initially to start with the Medicare claims because we do have access to a good stream of Medicare claims for total cost. So this dimension is moving us from hospital to other services, but also time-wise too, it's moving us from a particular 2-day hospital episode to a 30-day or even a year time frame. So if you expand that time frame to what kind of adjustments you need to make to that measure to make it more level field. So those are all the questions that we would be dealing with as we move from one particular hospital per case to a total cost. And as I said, this is also going to be in relation to what we do with the phase 2 application and how we would align our risk strategies on the phase 2 versus what our efficiency definitions are.
And Barbara, I would actually say that the middle one, the right-hand side is somewhat clearer than the middle one because the middle one is actually very complicated. And if you define an episode that starts with a procedure or an admission to a hospital, that's one way of defining an episode. The other way of defining an episode that some payers use is a condition. So the condition is back pain or arthritis. And so if you use a condition, then you start looking at per capita use of what happens. Does it end up in surgery or it doesn't end up in surgery? And so you start getting use rates too. If you use the other definition, then in some respects you may ultimately not take into account the hospital that spends money trying to prevent surgeries by encouraging population health and encouraging exercise and weight loss and all of those types of things. So that middle section is actually one of the more complicated decision trees. The total is more what cost do you include. Do you have pharmacy in, you have pharmacy out. But the middle section is really very complicated in terms of a decision thought process.
Thank you. Yeah.
But isn't that middle section one of the most important ones when you're looking from a Medicare perspective about total cost of care for a particular condition across the spectrum that includes not only inpatient care but outpatient management, physician care, drug costs, things like that, as a total cost of care?
Right, which I think is why Shuli is saying in some respects there may be some initial focus on, heavier focus on getting accurate total cost of care figures in place and being able to analyze the total cost of care first and then working the way backwards. So working from the ends toward the middle, and because we do need to get out migration and in-migration and lots of other things pulled together to accurately look at the total cost of care.
Donna, that was a very good explanation. I'm more familiar with the latter part of your discussion where you talk about episodes of care being around back pain or heart disease or something like that. And I truly think that you can't just look at that by itself. You also have to look at use rates to see if you're actually reducing the incidence of the disease in the community that you're being measured as well.
So there are a lot of measures out there. We talked about the Medicare spending per beneficiary already. As you all know, HSCRC has been using reasonableness of charges, ROC, ROC, in our efficiency assessment so far. And as we are moving to total cost, we are thinking about a population-based per member per month type of measure for total cost. So I'm going to go briefly on the ROC adjustments. The way the ROC has been structured is this notion of stripping out some of the costs associated with specific cases. So the uncompensated care, for example, is removed when we do these adjustments or assessments of efficiency. The other adjustments that we do are the cost of direct medical education, nurse education, trauma, labor market costs, the case mix adjustment, and also the indirect medical education, the additional costs that we don't see due to the medical education provided in the facilities. The other one is the disproportionate share. So this is the indigenous people and the higher costs associated with taking care of them. And finally, the capital costs. So these are all either removed or adjusted from the rate, so the comparison is done on a more equal basis. So as we are thinking about the new world, David already brought up the quality payments or adjustments, which we need to think about, but also in investments that we are putting on the population health. How do we deal with them? Do we do that in the beginning and expect some ROI and eventually put them all into the assessment? Do we have other adjustments that we need to do to look at the charges piece and making sure that we adequately adjust for it? So here,
yeah, no, I think there's just in terms of DISH with the expansion of Medicaid, I don't think the DISH calculation will be able to stand going forward based on the historic definitions that were used in the calculation. And then also I think there's a concern of making sure that that as you're measuring inside of a state that's undergoing change, of making sure that you're not, as I say, measuring your own belly button. And circular reference, making sure that we look at the outside of Maryland and in terms of some of the measurements that are being developed and whether we're getting reasonable answers based on looking at some outside indicators.
So IME and the DISH would be the focus for us to, in the coming months, to revise and look at those and see if we could come up with better methodologies to adjust for these two costs, in addition to adding additional adjustments to it. So in the total cost piece, we are going to first be focusing on inpatient and outpatient hospital expenditures, but hopefully if we can work with the Medicare data efficiently, we are hoping to simultaneously start looking at the total cost in addition to the hospital cost, and then focusing on annual per member per month type of measure for the evaluation. So as I mentioned, since we have the Medicare claims relatively easily available to us, we are going to start with there, and hopefully that will also give us some information for the out-of-state utilization, and we need to work through creating an adjustment for those if you're doing a per member per month calculations. APCD, the MHCC's claims are getting there, so we're hoping that the commercial information will be taken from APCD. And the Medicaid is the one that we need more time to work through because of the way that we receive or don't receive Medicaid information. There is a total cost template that the Medicaid MCO submitted to us at the geographical level. At least we know hospital versus non-hospital utilization and spending. So even if we may not do an actual data analysis, we may infer some adjustments using an aggregate level of reporting. On the risk adjustment side, on a population-based, we are going to be evaluating demographic adjustments, age, sex, socioeconomic factors, and the readmission work that we are doing may also inform both the DISH adjustment and the adjustments for per capita basis. And initially, our plan is to start with the virtual patient service area concept. So can we adapt the distribution of population based on the market share of each hospital and try to attach a denominator to a hospital? You know, the attribution came up as another, alternative, but even if we attribute the patients per se, we still need to attribute a population. So we think that the virtual patient service area could help us to come up with a denominator more so than us trying to attribute for this measure the actual patient seen by the hospitals. And as I said, the out-of-state utilization, we need to think about both the pricing aspect and also the utilization aspect of the out-of-state utilization for this measure. A lot of work.
Just had a couple of quick questions. Going back to the value-based purchasing, Medicare's efficiency measure, that is applied at a national level. They can't apply. They can't do the efficiency assessment at an individual hospital level, correct?
Correct. So we've been discussing. It came out from the IOM geographic variation reports that they did a couple of years ago. That there is no, because of the way our rates are structured, they are stripping out the GMEs, DMEs from the rates nationally. Okay. But we don't have specific numbers for a similar adjustment. So it's been a challenge to come up with a similar measure.
The state as a whole.
Right. Yeah. Recently, they told us that they were starting from ground up. So they were putting our claims through the pricer and then don't add any additional adjustments. I noticed in the Medicare dashboard, state average inpatient is same as national average. I don't know what it is, but I know it's different than the national average. But that kind of made me to think that they just implemented the national average for our hospitals, and they're not calculating appropriately for the hospitals. We may need to connect with them again to see what they did, to understand what they are doing. They were aware of it. They were working for a solution, but I think their funding got cut.
Yeah, okay. Just had a curiosity there. And also the all-payer claims database of the MHCC, what shape is that in? Because I know a number of years ago we looked at it. It seemed incomplete. It also, there were significant delays, upwards of 2 years. And I just don't know how good of a source of data that is currently, whether they've improved it or not.
I actually will turn to David on that one.
So on an annual basis, they're running about 9 or 10 months behind. So 2014 data will be available at the end of this October. But they're also moving to a quarterly data collection process, and we're working with them, so we'll be able to at least get some early indications on a quarterly basis going forward.
They collect Medicare and Medicaid data also, in addition to all
Medicaid is somewhat incomplete, which is why we've worked directly with Medicaid to start getting total cost of care data from Medicaid, from the MCOs ourselves. We're getting all the Medicare data ourselves now, so we have that. So it's really the private commercial pay, and then they seem to have pretty robust data. Some of it hasn't really been analyzed before, so it's going to take a little bit of work and scrubbing, but I mean, we think the data is there.
It won't get clean until you start using it. You know that of all people, right, Bob? So so I think we're about ready to use it, and we'll find out how good it is.
Can I ask a question just about? Sorry if it complicates the conversation, but I have seen good data in our provider side, physician provider side, all cost data, Medicare data, and they're very nice comparisons with nice utilization data that's broken out by disease state, and how we compare, even in a place like Hopkins that's considered to be more expensive. In our large provider group, Johns Hopkins Community Physicians, we have lower than average total cost of care, and we largely use Hopkins providers, so it speaks to that total cost of care issue. What are the plans for trying to marry those databases and the approaches from the primary care attribution side, where payment models on the primary care side are also evolving towards, risk and total cost of care? Yeah. Are those conversations, is that part of the other group's scope, and are we ultimately going to merge those conversations?
I think those conversations are about ready to restart. Part of those conversations are going on inside of CRISP, who is working with the field to collect information and distribute it. But also, those conversations are going to be going on from a strategic level. We're focusing on trying to have a strategic vision completed by the end of the year, and then there will be a lot of hard design work after that. But I mean, I think there will be a lot of conversations about attribution and patient self-selection. I mean, we have a lot of mechanisms that are coming into play now with the Medicare chronic care fee, where patients actually sign a form to say who is their care manager, and so can we actually start to allow the patients to tell us who their primary care physician is, or their chief care coordinator? And so I think those conversations are just about to begin to start moving that thought process forward, and ultimately to hopefully bring that data on a more comprehensive basis, instead of just having who's in an ACO, but all of the Medicare patients in the state, and start to be able to bring that data back to the providers. So I think that's a conversation that is beginning to be in progress.
And is it linked at all to the work that the MHCC is doing on an all cost? There's just a work group that's just getting kicked off that I know that we're participating in, that's looking at total cost of care from a primary care perspective. Forgive me for asking, but are these conversations linked together, just so I can...
We are trying to link our state efforts together. There's a lot of different efforts in different agencies. We've been making a very significant effort to try to link them together.
Yeah, and nothing disparaging by the comment. I'm just trying to understand how we can be participating, from our system's perspective most effectively. So thank you.
No, it's a good point, because it is a challenge to keep things linked.
Shule, could you talk for just a couple of minutes on timing? Because I know there's first the issue of the ROC and potential changes you make for that, and how that may or may not be used for some of the the partial or full rate applications that are coming before the commission, and the timing of that. And then separately, to develop this separate efficiency measure or set of metrics, what the timing of that might be, either in terms of performance years and or when it would be used in a rate setting, setting of rates or an update process.
yesterday for the rate applications. So we are going to be focusing on the ROC adjustments in the next coming months, and I think our target date is, around December, right? That's what we are targeting. But in the meantime, as you know, when we are looking at this, we already start looking at the potential avoidable utilization in the rate applications, and we are incorporating some of that thinking, if not the exact methodology, to the ROC evaluations. And our contractor started like 2 weeks ago, and they are already jumped deep. Depending on our progress with them, as we are thinking about the ROC, and as we get the data structured, the per capita timelines are probably next 9 months or so. And I would encourage us to think about the way we are going to use it. I don't think that, we are used to the performance and improvement type of analogy with our quality programs. I'm not sure that is relevant for an efficiency, like that you would have a performance-based period, and then you have a performance period, and then you look at the improvement versus attainment. The efficiency is a different concept, and it may require us more thinking in terms of timelines and how we do the adjustments. One idea was to look at the outliers in the efficiency measure rather than doing a scaling. That could be one way. Certainly, the reviews are hospital-specific basis. So I think there are more different approaches. There are going to be different approaches looking at the efficiency. And, it could be a hospital-specific per member per month versus the total cost, and it may take us a while to get the total cost overall. So those are all we have to think in tandem with the methodology development.
And some folks have said that we should use a grid where we, we look at either an episode or a case, and then we also look at per capita. And so, if you have both, if you're high cost per capita and high cost per case, that's not a good place to be. And then if you're low cost per capita and low cost per case, maybe that is, gets you into an efficiency zone. And if you're high in one and low in the other one, maybe you're in the middle of the road. So I think that there's some thoughts about focusing on a grid type of an approach also that might be useful in terms of thinking. But I think we have to make some more progress, particularly on the per capita side, to really think about that. But we certainly don't want to have an efficiency measure that rewards hospitals that increase their volumes at the expense of per capita cost. That would be a mistake that we wouldn't want to make going forward.
All right, I think that concludes my section.
So I think we wanted to, I know we've had a long agenda, but there are some folks in the audience, and we wanted to see if there are any comments from the public. I don't see any volunteers for comments from the public, so I think we're ready to adjourn. So thank you for your prolonged attention, and we'll be back with you soon.